I chose to look into myofascial trigger points. I wanted to learn more about the methods and techniques as well as the scientific basis for this field of study. Looking a little bit at the history, though there is documentation of muscular pain studies and associated terminology dating back to the 15th century, the modern language and research was founded by Dr. Janet Travell. Travell was a medical doctor and personal rheumatologist of President John F. Kennedy and proposed the term myofascial trigger point in 1942. In 1960, she teamed up with Dr. David G. Simmons to further pursue the discovery of myofascial trigger points and myofascial pain syndrome. In 1983, Travell and Simmons published their work, Myofascial Pain and Dysfunction, the Trigger Point Manual, in a 2-volume series broken into the upper body and the lower body. As far as I have been able to tell, these 2 volumes, as well as the 40-plus papers that Travell and Simmons published, was and remains the gold standard in referencing information pertaining to myofascial trigger points among the healthcare community. This includes physical therapists, massage therapists, allopathic and osteopathic physicians, chiropractors, pain specialists, and of course myofascial trigger point therapists. So, what is a trigger point? According to Simmons and Travell, a trigger point is a hyperirritable spot in skeletal muscle that is associated with a hypersensitive palpable nodule in a taut band. The spot is painful on compression and can give rise to characteristic referred pain, referred tenderness, motor dysfunction, and autonomic phenomena. Autonomic phenomena would include things such as ringing in the ears, sweating, tearing of the eyes, skin redness, etc. Put in another way, trigger points are sensitive spots in skeletal muscle and/or the connective tissue surrounding the muscle that occur in a hypercontracted band of fibers within the muscle and tend to radiate or refer sensation elsewhere in the body when compressed. Trigger points are broken into 2 primary categories, active and latent. An active trigger point causes a clinical pain complaint. Basically, it's the pain a client is there or complaining about. It is always tender upon palpation. It prevents full lengthening and interrupts the full functioning of the muscle. A latent trigger point is clinically quiet with respect to its spontaneous sensations. It may not be actively causing pain until palpated. However, once palpated, it may cause all other symptoms of an active trigger point. Travell further divides trigger points into various other categories, which denote the location on the muscle, for example, central and/or attachment, whether the trigger point is a primary, i.e. it is activated by acute or chronic overload, whether it's key, which activates one or more other satellite trigger points, which is a trigger point induced mechanically or neurologically by a key trigger point, or associated, a trigger point that is active concurrently on more than one muscle. The nature and cause of trigger points is still not well understood, but it is believed that they form from gradual overuse, overload, incorrect use, or instantaneous trauma such as an injury. The proposed mechanism is that there is a gradual or instant, depending on the case, excess of acetylcholine that is released from the motor neuron into the muscle and through a multi-step molecular process releases calcium into the muscle fibers, which signals the contraction of the sarcomeres. Normally, the action potential in the motor neuron via the release of acetylcholine would stop and thus reversing the cycle. However, in this case, the excess dump of acetylcholine produces a continued contraction of the muscle fiber, which basically chokes out its own blood supply via the surrounding vessels. This, in short, creates an energy crisis where the muscle fibers need energy that the blood supply cannot produce. Furthermore, the muscle fibers stay contracted in this precise area of sarcomeres, which creates the nodule or bump that denotes the location of the trigger point. So treating myofascial trigger points, the idea is to disengage or release the hyperirritable spot, and that in doing so, the rest of the muscle and connective tissue surrounding the muscle will also release and lengthen. Thus, any pain or discomfort associated with the constricted muscle will be reduced, or in some cases, relieved entirely. The methods to address trigger points and the underlying myofascial pain syndrome that can be produced involves various iterations of injection and manual manipulation. In the early trials with Travell and Simmons, it included injecting local anesthetics as well as a technique called spray and stretch, in which the client would be sprayed with ethyl chloride, a local analgesic. This produced an instant sensory stimulus that would distract the client from the associated stretching of the affected muscles. Later, it was discovered that the same trigger point release could be achieved with injecting a saline solution instead of an anesthetic. This led to the discovery in 1979 of dry needling, which involved poking the trigger point with a hypodermic needle and letting it rest in the skin for several minutes. Though this technique was successful, it was very painful and led to the modern use of dry needling, which incorporates acupuncture needles. This technique applies the needle to the superficial area around the trigger point as opposed to the trigger point itself, while producing equally effective results. Additional techniques within the scope of manual therapy used to address myofascial trigger points include, but are not limited to, ischemic compression, tissue approximation, myotherapy, counterstrain, and stretching. So the current scientific consensus is was a little confusing to gain. While there are still many unanswered questions regarding trigger points and myofascial pain syndrome, the fact that they exist in some capacity does not seem to be in question. However, I did find one study from 2015, a critical evaluation of the trigger point phenomenon, that concluded quite strongly that myofascial pain syndrome caused by trigger points remains conjecture. That all working hypotheses derived have been refuted, and therefore the theory can be discarded. Despite this claim, numerous other studies and systematic reviews seem to support the existence of trigger points. Additionally, since that time, and though it is also disputed, advancements in ultrasound imaging and magnetic resonance elastography have produced studies claiming to image the trigger points. Without spending ample time with each study, reading the methods and statistical significance of the results, it is really hard to tell where biases lie and funding is set. Basically, is it sound science? One would like to assume that if a study is published in a peer-reviewed journal, that it is unbiased and objective. However, that just simply is not the case. Humans do science, and humans are inherently subject to their biases. Another interesting facet to this field is its historically absent uptake by the medical field. According to Simmons, the muscle is the orphan organ. No medical specialty claims it. Because of this fact, the scientific research around muscle function, specifically fascia, has been limited. However, according to another systematic study from 2015, Trigger Points Then and Now, a historical and scientific perspective, Simmons' comments, as well as Travell's myofascial pain techniques and concepts, seem to be gaining ground in the mainstream medical field. When limiting a Google Scholar search to the last 3 to 4 years, I would submit that their assertion is relatively accurate. There seems to be a substantial database of studies, both clinical and review-based, looking at trigger points and myofascial pain syndrome with respect to specific muscle groups, pathologies, imaging advancements, and techniques. Based on my research, while the verdict is certainly not unanimous on all of the specifics, there remains ample research that supports the concept of trigger points and the continuation of more study. This gives me enough support to continue to pursue the interest of trigger point therapy while remaining vigilant to stay up to date on the forthcoming research. Thank you.